Aloha, everyone. I'm Tia Hartsock, and as Dr. Maxim said, I'm with the Office of Wellness and Resilience. Today, I have about 30 minutes to go through some slides and talk story about how we're thinking about childhood trauma and adversity. So I'm going to go through this kind of quickly, especially at the beginning. But as she mentioned, please, if you have questions, please drop them in the chat and feel free. And but we'll have some time at the end to kind of talk story. Um, I wanted to, I wanted to go through, oops, sorry about that. Let me go back to the beginning. I wanted to go through some information about our office and kind of share about who we are and what our kuleana is in the state. So if you want to scan this QR code, this kind of takes you to our website to learn a little bit more. But basically, we were established in statute in 2022 during EGA's administration. And as Governor Green came in, he appointed me as the director to stand this office up in his office and really think about how to implement this legislation that came from a trauma-informed care task force that was also established by statute. Our overall responsibility, our kuleana in this office, is to look at state systems to support them and strengthen the services within our systems, to really think about how we implement trauma-informed care across the state. We really try and look at systemic barriers to well-being and think about that in a broad kind of scope from keiki to kupuna. So really thinking about the entire Hawaii community and how we can think about improving social determinants of health, and really thinking about ways that we can do this in trauma-informed ways. So when I am looking at this idea of trauma-informed care, we had in 2024 Governor Green worked together, and after the pandemic, which unfortunately kind of showed everyone, we all kind of know what trauma is, but it gave us a really good idea of how trauma can impact entire communities, how it not only impacts our own individual, how it can impact our own individual functioning, but those within our communities as well. So we worked with Governor Green to look at an executive order, and he's thankfully been so incredibly supportive of this work, and really has engaged and has been passionate about what systems transformation can look like for our state, to really think about better ways of serving and improving the health in our community. So we're super grateful for that support. And as you can see on this executive order, which is on his website, and think about the ways of getting through trauma-informed continuum. So we've created this measurable continuum after the Missouri model that was established through some early trauma work. And so this is a guide for us. This executive order is a bit of a guide for us on how to engage with the departments and how to really think about operationalizing what trauma-informed care looks like in practice. When we think about our office priorities, and as we were developed through legislation and through a mandate, we took some time to think how we would implement this mandate and what those strategic priorities could look like. And so this is just a quick look at what our current strategic priorities are by topic to give you an idea of the things that we're working on. So a focus on transformation within our systems, a focus on workforce wellness, and really thinking about, again, as a response to not only COVID's impact on the workforce, but these ideas of cascading trauma like the wildfires, some of the financial trauma that's being that's impacting our communities. What does that mean for our workforce? And as we want to recruit and retain a healthy workforce and really understand what secondary traumatic stress does, and find ways to mitigate and better support our workforce. From some of our work, we've established ideas and a framework around what building community resilience could look like and what a disaster response, specifically focusing on mental health and well-being, from a lot of the work that we've been doing in Maui can look like for the entire state. The other pieces of our legislation talks about sustainable infrastructure and funding and really thinking about innovative ways of creating programs that will integrate trauma-informed care within our systems. I wanted to start off, since we're today talking about adverse childhood experiences, I wanted to start off with a quote about how the former president of the American Academy of Pediatrics kind of phrased it. Adverse childhood experiences are the single greatest unaddressed public health threat facing our nation today. And, they think about this quote from Dr. Block. He said it more than 10 years ago, and we're still working on this. He sadly passed away a few years ago, but I'm glad he got to see how the beginning of this culture change in healthcare is gaining more momentum. I really believe that this is going to be an exciting new initiative in public health and prevention moving forward within our state and across the country. The focus today is really on adverse childhood experiences. So I know most of you have probably heard about adverse childhood experiences or ACEs, but we want to think about them as preventable. We want to think of them as potentially traumatic events in childhood, such as experiencing abuse or neglect, witnessing violence, maybe living in a household with substance use, having people in the household with mental health challenges, or instability from separation or incarceration of the parent. Generally, adults who have had ACEs have more harmful risk behaviors and potentially worse health outcomes. So it's important to remember that ACEs impacts all communities. And in fact, the original ACEs study was conducted around 1997, primarily in a white middle-class community with families who had Kaiser health insurance. And so this was started off as a Kaiser study. However, what we know now from subsequent studies that have been done, some populations are affected disproportionately. So, for example, Native Hawaiians, Pacific Islanders, high school non-graduates, unemployed or unable to work, or those in lower income brackets, uninsured, underinsured, or those who are multiply marginalized and involved in multiple systems like the justice system, the child welfare system, and those also in subpopulations who identify as like LGBTQ+. And so we really want to think about, why do we care about preventing and mitigating the effects of adversity and trauma, and how can we do that on a daily basis? So when we face adversity and trauma, it activates our stress response. As you all know, it activates our stress response in our brains and our bodies. You probably encountered this many times throughout your day, many times throughout your years in this field. And maybe you've had a patient who has, or friend or family member, or community partner who's easily startled or been hypervigilant in the waiting, as they're waiting for you in the waiting room. And then when you take them back into an exam, they might have trouble regulating their emotions or have sudden change in their moods. Or maybe there's a patient who has a lot of chronic pain without a clear medical cause, even after looking at doing a bunch of tests. These patients might be reacting to something in the environment that could be activating their stress response and may be at risk of being re-traumatized. So when we think about this in children in 0 to 5, 0 to 18, but the young ones especially were especially sensitive to repeated stress activation known as toxic stress. And so think about toxic stress and how our bodies respond to the stress hormones that are being released. And because their brains and bodies are still developing, these repeated doses of adversity and trauma not only affect their brain structure, but it can very much so affect their brain function. It could help, it can affect the way that they develop immunity, the way that they release hormones, and even the way that their DNA is read. It can also look at how genes are, their genes are expressing. And so we want to break this down to the biology of toxic stress response. It can look like changes in regulation of hormones, including cortisol and adrenaline, nervous system imbalance, metabolic dysfunction, perhaps increased inflammation, and immune markers, and like I mentioned, altered cell replication and possibly cell death. So when we think about this in the cost, I know that we all care about this not only because of the costs, both financial, but also a major cost to human suffering. So these are really looking at levels beyond crisis. And financially, we know there was a recent study in a 2023 JAMA article that the ACEs cost Hawaii about $41 billion a year. Untreated ACEs and the impacts of ACEs over for folks in Hawaii. So I'm going to say that again. It's not 41 million, it's 41 billion. This data is groundbreaking from this JAMA article, and it's showing the economic burden of ACEs, the costs of this economic burden of, how we don't treat ACEs, what ACEs does in terms of ACE-related adult health conditions, what it does in terms of folks that are unable to report to work, unable to engage in insurance, unable to engage in the family home life, able to engage in taxes and being collected, all of those types of things. This number was calculated and comes from this idea of how much it costs to have this economic burden of not only experiencing adverse childhood experiences, but not being able to address them. So in the US adult population, about 63% of adults have ACEs. The national economic burden of ACE-related adult health conditions is about 14 trillion annually. And that's calculated as about 183 billion in direct medical spending and about 13 trillion in lost healthy life years, which is approximately 88,000 per affected adult annually and 2.4 million over their lifetime. So ACEs also accounts for approximately 28% of all US Medicaid expenditures, which I'll talk about a little bit later. They're also associated with increased risk of more than 40 health conditions, including 9 out of 10 of the leading causes of death nationwide, which includes stroke, diabetes, kidney disease, COPD, and heart disease, as well as depression and suicide. These health risks increase significantly when a child or adult has a higher ACE score, typically described as 4 or more ACEs, which is what is shown here at the bottom of this graphic. So we know there's a huge cost to this crisis when it comes to our health as individuals, our children's and our family's health, and our health outcomes as a population. So nationally, 2/3 of people in the US have experienced at least one ACE. And 1 in 5 in Hawaii have experienced, 1 in 5 in the nation have experienced 4 or more ACEs. But in Hawaii, that number is closer to about 1 in 7. But unfortunately, that has been trending up in recent measures. So we wanted to take a look at more local data from our recent Hawaii Quality of Life and Wellbeing Survey. We have a data dashboard with our partnership that we've had with the University of Hawaii's Health Policy Initiative since 2023. This data is from our 2024 survey, and we're getting ready to distribute a 2026 version in a few months. You can visit this health dashboard at health-study.com. It's health-study.com. And this is a publicly facing dashboard. You can look up for all these details. You can sort. You can look at across the top. You can look at sorting by county, by age, by race, etc. And really kind of dive into the data in these different areas. This is the first data set. This one is the largest we've had in Hawaii related to health and well-being and social determinants of health. And it's the largest data set right now in the country using measures from the Centers for Disease Control's Worker Well-being and Quality of Life, the WellBQ. It's very comprehensive dashboard. It covers everything from disaster preparedness to workforce wellness. So please, if you have time, check it out and give us your feedback. We'd love your help in spreading the word about the survey, and we'd like to get some more rural participants in our 2026 administration of the next survey. So we wanted to dive into our ACEs data just a bit here. I can give you an idea of what the dashboard offers. For example, this is a screenshot from the dashboard that shows many Hawaii residents have experienced adverse events in childhood. Just over half, about 54 respondents, indicated that they've experienced verbal or emotional abuse at least once before the age of 18. About 1/3 said they've witnessed adults in the home being physically abused, physically hurting each other, about 35%, or experienced physical abuse themselves. About 1 in 5 reported being sexually abused during childhood, about 21%. So from this data, we see that similar to national findings in Hawaii, ACEs are strongly linked to more unhealthy and sleep-deprived days in adulthood. And across the board, exposure to ACEs is associated with a significant increase in number of monthly physically unhealthy, mentally unhealthy, or activity limited days, or lack of sleep days. So alongside these risks, we also measure how positive factors can make a difference. Most residents reported growing up with a supportive adult who made them feel safe, about 87%, and ensured their basic needs were met, about 90%. So having at least one caring adult around in childhood is extremely protective, which means this gives us a lot of hope, and that we have to obviously have in this work. Supportive childhood relationships are linked to better adult outcomes. Respondents in our survey who told us that an adult made them feel safe and protected in their childhood reported fewer physically and mentally unhealthy days, less sleep deprivation, and more hopeful days. Similarly, having an adult around who tried hard to meet their basic needs was tied to fewer unhealthy days and more hope for the future in adulthood. Again, hope is really key here. We have a lot to be hopeful for around here, and trauma and adversity can be prevented and mitigated. And so that's what we want you to remember today. This data is so promising and also aligns with the historic Kauai resilience study, which we should be really proud of in Hawaii from a research standpoint. As a longitudinal study done over the course of 40 years, the Kauai Resilience Study was so revolutionary when it decided to study protective factors, and it found that positive childhood experiences can make all the difference in the trajectory of a child's life. Namely, having a close bond with at least one emotionally stable person who was sensitive to their needs was literally life-changing. So when children don't have this, many times children might not have this when intergenerational trauma takes hold. So I wanted to talk about this Nadine Burke-Harris quote. It reminds of us how tiers of trauma work. It also starts with us first, and we have to understand that our own trauma and adversity affects us, and then we can better understand how it affects our families, our colleagues, and those who we supervise. So once you understand how your body and brain are primed to react in certain situations, you can start to be proactive about how you approach things. You can identify triggers and know how to support yourself and those who you love. So I love that quote, and really kind of ties into this work is not just about those who we serve, but it's really about us and starting with us primarily, and within the context of our families, and how we show up in at home and how we show up at work as well. So this leads to some really exciting news. Hawaii's been chosen to be a part of a cohort with of 5 states total with the National ACEs Resource Network, which is led by Dr. Nadine Burke-Harris. Beginning in 2026, our office will serve as the lead, and it's called the anchor agency in this effort. We'll be focusing on connecting policy leaders, clinicians, advocates, and community organizations in this movement. It's going to take every single one of us doing this work together to create meaningful and systemic and long-term change. We are also looking forward to being part of this very first state Medicaid policy learning collaborative as a part of this network, which will allow our state Medicaid office to build the critical infrastructure we need to tackle this program. So we're working with both Queens Medical Center, JABSOM at UH on this so far, along with Hawaii Community Foundation, and we're looking forward to working with all of you as well. So we are really, this is going to get launched next month. The first part of it, the Medicaid State Policy Learning Collaborative, and then we'll be working pretty deeply with the ACEs Resource Network in the second part of the year to build in our within the Office of Wellness and Resilience to really connect the policy leaders and work with clinicians on this framework. So I love this slide because I've been working in the trauma-informed care field for a bit now, and a couple decades right now. And so I love the idea of this framework through the development of the Substance Abuse and Mental Health Services Administration, and watch it evolve over time, and really think about how to integrate ACEs and early intervention. This framework considers adversity as well as trauma when it comes to health outcomes. And so in a healthcare setting, this can look like, number one, when we think about the health of our workforce and seeing the effects of burnout or moral injury, and other secondary traumatic stressors in the workplace, especially stressful frontline healthcare workers. You all are our essential workers. That pressure takes a huge toll. And when we have to do we have to do more to create a trauma-informed workplace for both ourselves and our colleagues, as well as our patients. And so this can include assessing our policies and procedures to make sure we are accounting for the 6 trauma-informed principles. For example, do people feel safe in the environment? Do they feel safe in relationship? Is there trust and transparency about how decisions are being made? Are they given choices in their work, in their care? And too many times, both in organizational leadership and administration, and then in a clinical setting for patients, decisions are made without people who are most affected. And so we've moved a lot towards inclusive decision making, not only in our state departments and our administrations, but as well as in settings with patients. So that has been huge steps in the last several years around that inclusivity and that integration of trauma-informed care in our settings. Now, what does this look like in a clinical setting? I didn't want to leave you without any idea of what this means clinically, but I also don't want to get too lost here with limited time. So I want to highly recommend Dr. Burke-Harris's Roadmap to Resilience report. She has written that when she was California's first Surgeon General. It's in the bibliography at the end of this, so you can reference it. It's an extremely comprehensive roadmap, but this is a part of it. This is a simple piece from the report This is from the California's model, and it shows how we can use a meaningful and supportive approach that emphasizes strengths and intervention options for managing toxic stress. For example, an adult patient found to be at low risk of toxic stress, defined as an ACE score of perhaps of 3 with no associated symptoms or conditions. And with a number of protective factors, they may not need additional interventions or referrals beyond patient education. However, when we look at a patient determined to be at intermediate risk of toxic stress with an ACE score of 1, with symptoms of depression or poorly controlled asthma, with limited social supports, they may benefit from specific interventions that target toxic stress response, as well as referrals for community or mental health resources. This can be even more powerful with a patient education plan that centers their needs and what they want their life to look like and feel like. This is a framework graphic again from California's model. But when I look at this, I immediately think of the Lokahi wheel. Kamehameha Schools created a Lokahi wheel with 6 different domains of what a balanced life looks like. And so we're really excited to think about creating our own culturally responsive model here as we get started in this work. All of these components kind of get us back to the basics of health and well-being. And all these pieces here of this pie have been shown to reduce stress hormones, really reduce inflammation, and enhance neural plasticity, which we know are key mechanisms to offset the toxic stress response and improve overall quality of life. And so maybe take a second to look at these and think about what aspects you integrate or reintegrate into your own life and self-care plan. I've been working with some public service systems for a couple of decades and really think about how this work in the education field and when I worked in the prison system and in the judiciary, child welfare. And the reason I got into this work really was because I kept seeing the same thing over and over again in the people that we were serving, and it was trauma. It's really, we spent a couple of decades thinking about increasing awareness and really trying to educate on what trauma does and how it impacts our lives, and how to then, build in resilience. And so when I take what we've learned about trauma over the last 20 to 30 years and start to really think about how we're doing this on a large scale, on a systemic level, and really make a difference. So at the end of the day, that's what really matters. We want to think about quality of life and how we experience the short term we have here, the quality of life we experience, and how we can help others have a higher quality and reach their goals in terms of building more resilient communities. I also personally want to do more to prevent and mitigate trauma here in Hawaii. I know it can make a huge difference in our communities and our health outcomes. So I'm looking forward to working with you all to do just that. I want to mahalo you all for showing up for today and slowly taking this all in. I know it's a lot. I know this is critical work that you folks do every day. This is critical for our state and to be done not only on a systems level with policy and program development, on a national level with policy and partnerships across the states, but what you folks do every day with inpatient settings. So I know it can, be there's so much to dive into when it comes to what toxic stress looks like, and what it looks like not only within ourselves and how we regulate ourselves on a daily basis, and how we teach that to our families, what it looks like in our neighborhoods, but really think about what we can do, not only just starting with us, but then really modeling it for all those around us. I think we have a huge opportunity to make a big impact. And so thank you for the work that you folks do on a daily basis, and choosing to continue to show up, and really think about how not only we show up for ourselves every day, but we show up for our families, for our colleagues, and supporting them through these different times. And then also, of course, showing up for our patients every day. So thank you for that. I wanted to turn it over to Dr. Maxim about the poll questions. I think I'll leave it at that. Hopefully, gave a pretty decent overview. I'll turn it over to you, Dr. Maxim.
Thank you. Yeah, that that was amazing. Thank you so much for sharing about the work that you're doing. And I personally have at least like 5 or 6 questions that I jotted down while you were talking, but I want to make sure everyone else has a chance to ask some questions too. So maybe we'll start with the poll. And what we typically do is we just briefly go over the questions. So I'm going to launch the poll. And then we'll give everybody about a minute and a half or 2 minutes. And then if everyone gets the questions right, you don't necessarily have to spend too much time on it. But any of the questions that folks have a little bit of, if there's some spread on the answers, we like to just go back over those and clarify what the correct answer is. Would that work for you? All right, folks, go ahead. You should be able, please unmute yourself and let me know if you can't see the poll, but according to me, it has launched and should be available for everybody. Yeah, everybody, we'll give you about another 45 seconds or so. And then think about any questions you might have too after we look at the poll results. This is a great opportunity to find out about what's happening in the state and how we can best collaborate to serve our patients and to help to mitigate some of those effects of trauma. Okay, about 5 more seconds. All righty, I'm going to go ahead and end the poll. And I will share the results. Okay, are you folks able to see that? Okay, great. So whoops, I just made it go away. All righty, so Tia, question 1, it looks like most people got it right. One person, I think, had selected just changes in regulation of key hormones rather than all of the above. I don't know if you want to add anything about that.
I mean, I think the idea is really thinking about when we're looking at what release of hormones does to our body, and how it changes the different markers. It can change different markers like the metabolic dysfunction. We really think about a huge piece of extended and prolonged exposure to stress. Thinking about how it increases and continually releases adrenaline and cortisol. And so that inflammation that occurs over time, what we kind of talk about is the prolonged exposure to stress that continues you go home to neglect or witnessing violence, then you go to school and get bullied, and then you get beat up on your way home, and it's just this constant impact of this exposure to stress and this high level of stress hormones being released continuously in your body.
Thank you. And then for question two, it looks like everybody got it right. Which of the following is not an example of a behavioral, emotional, or physiological indicator of trauma and toxic stress in those we serve? And everyone correctly checked consistent attendance at scheduled appointments and proactive health-seeking behavior. Um, did you want to add anything about that, or should I go on to question three?
Um, I mean, I think that when we look at, the different levels of toxic stress, you have, kind of like normal stress or healthy levels of stress, which is like, stress of taking a test or stress of going to a game or stress of, moving. But then you look at the next level, which is the um, what do they call it? I'm trying to productive stress, I think, is what they refer to it. So you have the normal kind of levels of stress, and then oh gosh, let me actually have it right here. Let me look. Um, you have positive stress, sorry, not normal, positive stress, and then you have tolerable stress, which is like it could be something that is occurred by a natural disaster, so it's time limited, and then you're able to tolerate that level. But then the toxic stress is really like this constant dysfunction, this constant chaos. And so it's always kind of showing up in the ways of not only behavioral um, uh, indicators and markers like in school, but then you're also not able to regulate emotionally. And then you really look at how that starts to impact the physiological self. And so, yeah, it's showing up in many ways in the body, in the mind, and in the action.
And I would add too that a lot of times I think for us as healthcare providers, we feel like it's targeted towards us. And
Mm,
just
right.
remembering that when people are having a trauma response or some kind of exaggerated emotional outburst, it's almost never, I mean, of course, we should take responsibility when we do things wrong, and when traumatic things happen in the healthcare setting. But the vast majority of times it has absolutely nothing to do with us, and we're just the one that's standing there. And so thinking about ways to de-escalate and to show compassion, even in those moments where you feel like you're attacked, I think is challenging, but it's something that it's really important for us to work on as clinicians.
Yeah, we always kind of structure it in the moment we start to emotionally respond to somebody, like I'm a social worker by training, so as a social worker, the moment we start to emotionally respond to behaviors that I used to work in a residential facility. And the moment the idea is like, oh my gosh, this kid's being so disrespectful to me, you're gonna get this, and this, demotion in the program or whatever.
Mhm.
The moment we have that emotional response or our stress levels start to go up and say, oh, how disrespectful he's being to me. That's when our stuff comes in. Well, what is that? Why is it about me? It's not about me. It's about his, or her, their inability to not only regulate, but also we think about it as as an adaptive survival mechanisms. It's not a maladaptive, it's a very, they're able to keep themselves safe and survive. And that might be acting out, that might be running away, that might be getting physical or verbally assaultive.
Yeah.
That's be their fight, flight, or freeze response.
Yeah, absolutely. The third question was about the economic cost. And I think, it is staggering the number. So the correct answer for everybody who might have missed that question is $40 billion, billion with a B. And as I would just say, as somebody who engages in political advocacy, and I'm always coming at it from the point of view of like a bleeding heart empath, and I want all good things for all good people, but it's important to think about the money. And so when we have the capacity to think about how do we spend state money, or sometime in the future when we have a functioning federal government, how do you use federal monies to kind of do the most good for the most people? When you're looking at this cost that nobody is covering of all this lost productivity, it really reinforces why these are good investments. And so it isn't those little things where lazy people just trying to leech off of the government. It's really much more about, even if you look at it in purely economic terms, there's a massive return on investment if you invest in prevention and mitigation of ACEs. Sorry, I went off a little bit. This is your presentation, Tia.
No, that's perfect. And I just put in the chat, the
Thank you.
bibliography was the last slide. So the second, the Peterson article is the economic burden of health conditions associated with adverse childhood experiences among U.S. adults. So that's the JAMA article, where it dives into how they calculated that number of 40 billion. It's hard to believe. They calculate it very systematically and very comprehensively. So if you're interested in how they got to that, there's the article.
Thank you. Okay, and then question 4 looks like everybody got it right as far as some of the major aspects of a trauma-informed care framework. Did you want to
Did
add
you?
anything about that?
I think an exciting piece that we're kind of working on right now, and we just launched and we're about to launch statewide, is a trauma-informed care certification program for the state, for state employees. And really, we just trained about 175 state employees a couple of weeks ago. And with first 4 modules, and then the second 4 modules are going to be released in January. So it's an 8-module certification program that any state employee will have access to in January. The first 4 will be asynchronous, that they'll be able to take online, an hour each, and then we'll be rolling the last 4 in the 8 modules that will be delivered live on a regular rotating basis. So we're really excited about that certification. It's the first state certification that we've had. Other states kind of have this. They've created their own state certification program. But yeah, it's really exciting to get one up and running.
Thank you. Yeah, Linda was just asking about dissemination plans. So, and then said you just answered that question. So yeah, I agree with everyone who's commenting that's wonderful. I'm curious. So state employees. So like all of the JABSOM, not all of, many JABSOM faculty are sort of like 5% state employees. That includes me. I'm mostly employed by Hawaii Pacific Health. But then I have like a 5% at JABSOM. Would that then apply to us when I think about, the large group of clinicians who are providing care? Not everyone is faculty, but a lot of folks are either a volunteer faculty or have like a small percentage of their time through JABSOM.
So we're working with the judiciary and the DOE are kind of on separate learning management systems as is UH. So we're working to integrate the learning management systems and just kind of hand over the modules. It has to go through like a quiz at the end. They've got CEUs attached to it, so there'll be 8 CEUs total to get a certification available. And so we have to track it. So we're working with UH, we're working with DOE, and we're working with the judiciary to get them on their learning management systems. But the goal is to have our own. I need to find funding for that. The goal is to have our own learning management system on our own website. To launch so that anybody in the community, any public person can access the certification and then take it. We just have to track it so that we can provide certification. And so, yeah, it will be free. It's developed with state resources, so it will be free. And it will be, again, the first 4 modules will be asynchronous. They will be online. And then the last 4 modules each module is an hour. The last 4 modules of the 8 module series will be delivered live. And the reason for that, we fashioned this certification course after a trauma-informed care course that I helped develop. I co-developed with several other people and taught it at UH School of Social Work the first time I taught it was 2020. Well, we launched it in 2021, I think. And we developed that syllabus with about 25 people across the state, had it reviewed, people with lived experience looked at it, and a lot of partners that do trauma-informed care with me co-created that syllabus. And so we took the syllabus and expanded and applied new research. We applied more components, but we learned a lot I've ran that class through 2 times now at the School of Social Work. And so from what we've learned in running that course, at UH, we've been able to expand it to this certification program and have just run the whole thing through about 20 what we call friends and family. And so they've given us a lot of feedback. And so we're just in the final stage of making changes to it and integrating some feedback and then launching it in January. So it will be free. The first part will be online and the second 4 will be delivered live throughout the year. We'll be delivering it live.
So Michelle asked that she was wondering about how to access it. So I know you mentioned it would be available in January, but once it's available, is there an email list folks could sign up for? Or is
So
there...
sorry. If
No,
you're
go
a
ahead.
state employee, it will be on the Department of Human Resources Development, the DHERD website. Every state employee has access to the DHERD website and will be able to access the first 4 modules asynchronously. But again, we're trying to get our own learning management system up to be able to put it on our website and then launch it for the public at some point in 2026.
That's wonderful. And it sounds like it's all very locally created. So although I'm sure you used a lot of sources, from the continent, presumably a lot of the cultural and other
Correct.
examples are very Hawaii specific and would be relevant for folks living and caring for community
Absolutely.
members here, right?
Yep, for sure.
Because
We've even
that's something
adapted
we
the
found a lot.
continue. Yeah, absolutely. We've even adapted and are starting again to kind of create our own indicators for the continuum. So that is going to be launching next year, or in 2010 next year, in a month, in less than a month, in January in 2026. So that will be there as well. So it's a helpful kind of, we'll have some tools up that will hopefully help organizations kind of show where they are in terms of a continuum and getting to be working towards becoming trauma informed, where you're looking at really revising policies and practices and procedures on a daily basis. Everyone in the department or the organization is trained and has a common understanding of what trauma is. People are engaged in trainings all the way from clinicians to part-time employees, seasonal employees, frontline workers, people who answer phones, like anybody who works in an organization. We really, the best practice model is really to get everybody trained.
I remember when Dr. Burke Harris came here as a speaker a few months ago. She talked about a program that was specifically for pediatricians, I suppose, in part because she is one, and in part because if you intervene in childhood, that has the biggest impact. Where they were doing specific training for pediatricians in the state of California on screening, but I think also on appropriate response when screens are positive. And Sharon Thomas was here, but she's not, she seems to have had to step out. But I'm curious about, from our perspective as clinicians, are you anticipating something like that? And if so, is there a way to make sure that busy pediatricians are reimbursed for screening and interventions for ACEs, where a lot of the so-called touchy-feely stuff often doesn't get reimbursed. And so many different screenings that, we're asked to do, it becomes really challenging.
Yes, thank you for asking. I'm gonna so so this is we're looking at on the slides. We were looking at this slide, really talking about, so we did get selected as one of 5 states that will be engaging in this ACE Resource Network collaborative. So there's 2 pieces to it. So our office will be the anchor agency for the whole collaborative, but the 2 pieces of the collaborative, one is the Medicaid state policy learning collaborative, and the other one is this state and national coordinated collaborative, which is where my office will be working with the 4 other state offices that are the anchor agencies to develop to coordinate clinicians, to get healthcare providers trained up in how to do this brief intervention. The Medicaid State Policy Learning Collaborative, which our Medicaid office is leading, is going to be working with the other 4 states to create the mechanisms within Medicaid to get that reimbursement for a brief intervention. So they're going to develop the code, they're going to develop the content, they're going to develop the markers. And so they're going to be working to get that whole system set up within the Medicaid office to be able to have clinicians bill for a brief intervention to not only identify toxic stress, but be able to do that intervention with the parent and the child, and then be able to work as we set up this 3-year collaborative, to be able to work within the system and create and build and kind of help stand that larger system up so that we can do really really good referrals and appropriate referrals to community partners within the system of care. So
Thank you.
yeah, so that's what we'll be
Really
doing.
exciting.
That it's launching in next month with the Medicaid State Policy Learning Collaborative. So Medicaid has already said, they said yes a month ago, and so we're one of those. We're one of the 5 states. I think the other 4 states they haven't quite announced it, but they'll be Dr. Burke Harris and ACEs Resource Network, the National ACEs Resource Network, will be announcing those states when they launch. There will be red states and blue states. I'll just say that.
That's
Which
good.
was very intentional, very intentional.
Yeah, it's super important to make sure that everybody has access to those services and to that knowledge that I'm sure you'll be learning a lot too as you go through that.
Yeah. And we're hoping to be able to, circle back to folks in this arena to be able to when those trainings are going to be coordinated, and we're hoping to partner with you folks to be able to offer those and train on the codes and train on the intervention and all of that. Yeah.
Yeah, we would love to have you back for some of that for sure. Thank you. All right, folks, this has been an amazing conversation, not just a wonderful presentation, but also a really wonderful conversation afterwards. I think we learned a lot and also have a lot to look forward to. We have just like 1 or 2 or 3 minutes left. If anyone has any last questions or comments, please feel free to unmute yourself and ask them or share your thoughts. Lots of thank yous coming through in the chat and reactions and emojis. All right, well, I think we can go ahead and wrap it up. Everybody got 2 minutes back of their day. Really looking forward to having you back, Tia, to see how else we can collaborate. Thank you very much.
Thank you so much. Have a great day.
Bye, everybody.